people are sicker now. And especially now, mental health is such a disaster. We're seeing so many people come in just suffering depression, anxiety, brain fog, new onset psychiatric problems, I think as a result of the last few years. And if it was important, 10 years ago to collaborate, how much more important is it now?
I am so delighted to be part of this conference. I applaud Kirkland for really taking this and turning it into this huge, important tool for all of us to learn from, and all of these great speakers and many mentors and colleagues on the stages. And I do look forward to next year doing it live. I think that's going to be such a wonderful experience. So I hope we see you face to face there. Today, Dr. Mather and I are going to talk about something that both of us do all the time: integrative and collaborative approaches to mental health. So these are our learning objectives. We're going to hope that by the end of this talk, you're going to understand collaborative care tools in mental health and primary functional medicine. You'll be able to lay the groundwork for collaborative care, know some of the root causes and some of the workups for the most common mental health complaints, and understand and be able to use some tools to treat some mental health complaints. So I want to start off with a patient example. And this is a real patient that was 43 years old when she started seeing myself. And she had dysthymia beginning 7 years prior to that. And she came to me with a mental health complaint, and you'll see this acronym, MHCC. Her chief complaint was dysthymia and fatigue and panic attacks. So what do we do? Well, I initially started some pharmacological treatment with a mood stabilizer, lamotrigine, with an AED that was acting as a mood stabilizer, lamotrigine, and escitalopram. And she had partial success with that. And after a good clinical workup, I usually do a blood workup unless they've had something done recently. And then with that in mind, I reached out to Dr. Mather to collaborate for further workups, including treatment planning. So I reached out to Dr. Mather because even though, we have a mental health chief complaint, and those of us in the mental health space, we really need to know that there are underlying biological and other root causes. And that's what we're here to talk about today, and how we can collaborate with those. So what is integrative medicine? So I'm just going to read this quote. It reaffirms the importance of the relationship between the practitioner-patient and focuses on the whole person. It's informed by evidence and makes use of all appropriate therapeutic and lifestyle approaches, healthcare professionals, and disciplines to achieve optimal health and healing. So integrative medicine, one individual can call themselves an integrative medicine practitioner, for sure. And many of us do call ourselves that because we ourselves are focusing on a whole person, using appropriate therapeutic and lifestyle approaches. But we also need to do collaborative medicine to really inform and best upgrade to a true integrative nature. Collaborative medicine is just what it sounds like: different disciplines and different specialties. I like to think of what I do and what Dr. Mather and I do together sometimes when we are able to is transdisciplinary medicine. They use that in the business field all the time and in science, but transdisciplinary medicine integrates and transcends their traditional boundaries. So instead of just multidisciplinary, where two of us each see the patient and then I make my treatment plan and someone else makes their treatment plan, and then the patient is the one that is seeing multiple specialties. Interdisciplinary, I make my treatment plan, someone else makes their treatment plan, and the patient then is, maybe we communicate our treatment plans together, the specialists. That's kind of 1 + 1 = 3 in my mind. But transdisciplinary, and what Dr. Mather and I have done, is where we actually do a workup together on a patient, brainstorm about what the best workups would be from both of our separate perspectives, which you'll hear about, and then be able to really influence the patient's treatment plan from a together transdisciplinary team. So what are some of those tools we'll talk about collaboration. We really have to have a referral network. And so having some people on speed dial and some people in your that understand what you do and understand how you and the other treatment providers can support each other. Because collaborative care truly does increase effect and outcomes, especially for mental health, all ages, including substance use. And I specialize in addiction as well. And, you know, many individuals that see me already have a primary care. And many individuals that see primary care might not have a psychiatrist. They might not have access to any mental health care. And so being able to have a close referral network, you know, a multidisciplinary team that maybe collaborates and maybe even has a multidisciplinary team meeting, those can be so helpful for patients that are struggling with mental health issues. We really want more information sharing. That's great that some of the EHRs do that, but it's not through and through. And we want to be able to share and collaborate on patient information, lab workups, treatments, but quick communication. Because when I order medical records from the hospital, I might get them 3 months later. So having, like I said, people on speed dial, yes, with a release of information signed, but making it so that you can have quick communication so that you can collaborate on treatment plan. I know, Dr. Mather, you want to talk about this. Don't stop someone else's treatment. We want to respect our colleagues, because if you're like, oh, that practitioner did this, I can't believe you were put on that, then you're really undermining the patient's ability to trust the medical system. So even though you might not appreciate someone else's treatment, you really want to help the patient respect the medical system so that you can continue to keep them to come to you. Someone else might undermine your treatment if it doesn't work, or maybe it had a side effect. Okay.
That's right. That's why I made you put it in bold, right? It's just, we see this all the time. And maybe one of the big reasons why we're both here side by side is we both practice in New Orleans. And what we've learned over time, as we've leaned on each other's skill sets, is that our patients are doing even better than they would had we just saw each other separately. So what Arwen and I have been able to do over the years is not just communicate on the patients that we're jointly seeing, right, to make sure that we're having treatment plans that don't run on top of each other, or that I'm not saying, I can't believe that Arwen started escitalopram here, it should have been this, right? We can have a conversation, and then the patient understands that people are on a team to get them better. And from a personal perspective, it's just fun. I mean, forget all of the studies that show that when the more collaboration that happens between practitioners and specialists, the better outcomes we get. It's so much more enjoyable to be able to shoot Arwen a text and say, Arwen, I'm seeing this and this and this. Is this the right plan, or should I be doing something else? It's fun. It really helps. And the biggest picture when we were talking about getting this talk together off the ground was, people are sicker now. And especially now, mental health is such a disaster. We're seeing so many people come in just suffering depression, anxiety, brain fog, new onset psychiatric problems, I think as a result of the last few years. And if it was important, 10 years ago to collaborate, how much more important is it now? Because our patients really just deserve to have everything they can for mental health. So let's keep going on, but I wanted to jump in and say that.
100%. And look, because of the need, we actually have so many more tools out there today, and even billable coding for collaborative care. So know that. I don't have the details. That's a whole nother lecture and discussion. But nevertheless, what we know is if it's billable, it has had some proof to work. And so we know very well that that's actually something that's happening. So we're going to get into what our goal is, really. We're talking about collaboration and integration approaches, but also about how Dr. Mather, Joe, and I see common biological root causes. What are some of the most common? What are some of the most common symptoms? And what are the most common workups and treatments of these symptoms and health concerns?
So I'll jump in here. And I think that the big idea here is that Arwen and I both have MD after our name, but we approach patients really differently. And I think what we found is that two different ways of looking at a problem has really helped our patients get better when we combine our treatment plans. And so, whereas I tend to want to take in a lot of information at one time from a patient history, and then jump right into what are the tools and treatments I need that I think are most likely going to get this person better, right? I really am honing in on lifestyle, because regardless if someone is just mildly ill or if they're are horribly neurotoxic from mold or chemical exposure, lifestyle is often missed. So I'll really almost always begin with lifestyle and then start coming up with a list of what are the tools I think I need to fix the problem. And I think about root cause as being uncovered when a treatment works, rather than a fundamental idea that I can get there with lab testing. And Arwen and I see this a little bit differently, and we'll kind of argue back and forth and have fun with that. But the way I see it is that people can often get overwhelmed with too many labs, right? We do need labs to identify problems, but there's kind of a sweet spot usually. And when I'm looking at a patient, I'm always trying to listen, okay, what are the tools? What are the treatments that help this person get better? And I typically want to start trying some therapies first and then go to labs second. And so that's kind of the treatment first approach that I like to use. And then I will kick it over to Arwen to talk a little bit, because she's truly the best psychiatrist I know. And I'm lucky enough that she's gotten me out of 2 bouts of major depression. And she is just truly gifted at the neurochemistry. And what I love about her approach is that it's not just being a master of the pharmaceuticals, but it's also being able to respect and understand what lifestyle tools need to be used, right? And then what nutraceuticals or what nutrients can she bring to bear to help a patient. So having the integrative and conventional is what makes her really shine. So Arwen, please help me understand how you approach most patients.
Yeah. And so it's so different because you're primary care, you're functional medicine. So people come to you with not necessarily like a chief complaint, but I think they come to you to feel whole and better. So whereas they come to me with a mental health chief complaint because I'm a psychiatrist.
Yeah. I have a symptom list of 12, right? And it's like, okay, where do we go?
And mine starts with anxiety or depression or, and so and then of course it filters out to all the things associated with that. So what I've done through the years is I have learned what a phenotype looks like. We have lots of different nutritionist specialists, lots of different ADHD specialists that have done, Dr. Hedaya has done a lot of the QEEG. So we can see what a phenotype looks like with clinical presentation. And then I, with my many years of having done genetic testing and seen a lot of labs and seen a lot of different workups, I think you do the same too, to a degree, just this is part of the art of medicine, is then I don't always go back and figure out, I don't necessarily do the testing, but I say, aha, this phenotype looks like this set of genotypes and pathways.
Yeah.
And so then I'm saying, oh, well, this is, and sometimes it's kind of embarrassing because sometimes I'm seeing a patient that is so pathognomonic for this one particular pathway gene, and before doing any testing, and they're miserable, and I'm laughing to myself because I'm like, oh my God, this is so easy. I need to address this and this pathway, and that's all, and we're going to get them better. And then I want to do the workup to show the patient. I try not to laugh in the patient's face, not at them, but in their presence, because it's disconcerting. But I know in my heart that like, oh my God, this is actually really easy. And I know they're having the most miserable time in their life, but I can show them through a workup and then start doing, look, I start with symptom management first. I don't try and do what a lot of people that are in the nutrition world are doing, where they want to build the nutrition and build the repair. I want to, like, I've got lots of medicines. We'll talk about medicines too. And so I want to do immediate symptom management because they're coming to me. I want them to come back to me. And so then I do some further workups and I look at root cause management and symptom treatment from a root and from like the baseline, and then prevention. And that's where we do a lot of the collaboration is in the middle and later stages there.
Great.
Yeah. And but it is so interesting to see kind of how different people come to me and different people come to you. And that's why we are doing this presentation, because we take different approaches, ultimately with a very delightful and thrilling outcome for the patient. So this is not an exhaustive chart, but this is a pretty exhausting chart if you look at it. On the or on the top row, we have 7 of the most common mental health diagnoses and symptoms. And I didn't put everything. Notice schizophrenia is not on there. I know we've talked about some schizophrenia and bipolar, but we are not talking about it per se here, but that doesn't mean that it doesn't also fit into this graph. And then on the left-hand column, we have really some of the most high yield dimensions related to root cause of these symptomologies. So where there's an X, there is correlation and and we have on the next slide, we have all of the references for this table, because it's not just theory, it's not just my understanding, it's been proved time and time again. So for example, if we look at anxiety, we can see that gut dysbiosis is related to anxiety, and we'll hear more about the gut microbiome. But you can also look across and see that gut dysbiosis is also related to depression, maybe to insomnia. We don't have that extensive list of studies for that. Definitely to attention issues, fatigue, thought disorders, and addiction. And then we have cortisol and anxiety. We know very well that elevated cortisol relates to high anxiety. Is it cause? Is it root cause? It's correlated. So we need to look at that and how we can address that. And then look at over towards the right, attention issues, people with ADHD, we want to lower their resting plasma cortisol in most of their cases. And then fatigue, we want to aim to lower. Fatigue often is a paradoxical cortisol response. So it could be the cortisol itself, or it could be the receptors, it could be the pathways, but it's just a cortisol related to this hypothalamic pituitary axis. So you can see this chart shows a lot of things. Let's go to nutritional deficiencies. And we're going to focus on this in a little more detail later. But with anxiety, we have some omega known problems. Selenium can improve anxiety, magnesium, zinc, and iron. And I think we see iron not across the board, but also related to depression and also related to fatigue. So I think, Joe, you have a case, huh?
Well, yeah. And the whole point of this slide is that when you're looking at that left column, we want to encourage everyone, when you're getting the symptoms to come in, just to be scanning through what is the root cause here. And what the rest of the presentation will be highlighting as many of those items in the left column as possible. But before the conference, I was just mentioning to Arwen, just the easiest thing in the world is looking for iron deficiencies. I just recently saw a patient who came in to see me from Florida, and she had seen 4 of the best well-known functional medicine doctors in the country, who everyone would know their names, and she got 4 different diagnoses, right? Is still suffering anxiety, depression, fatigue, unbearable fatigue, and no one checked an iron level, right? And her ferritin was a 5, right? So this was 10 days ago. I expect within 3 days of her taking some iron that she was improving. And I bet you she's close to back to normal right now, just by making sure we're not missing the basics. So that's one point that I just think it's just so important that we don't miss the basics when people are coming in for our care.
And so therefore, I do a baseline blood work, I do, but I don't do exhaustive blood work initially, but I have a pretty extensive panel, and I know you do too, because in psychiatry and mental health, if we don't address the biological, we're going to miss some severe symptom relief that we could do. Iron is certainly a key factor and really easy to test and really easy to treat. And then when we go down to genetics, we'll talk a little bit about methylation, which is a very commonly known thing in this audience, of course. The MTHFR gene is one of many genes that is highly linked to mental health disorders and other disorders. The COMT, tyrosine hydroxylase, MAO, HT, those are some of the other ones related, particularly known to be related to depression. That doesn't mean that we have to do a genetic workup. And like I said, I have done so many genetic workups, and I do use particular gene companies. But I have done so many that I often can see what the phenotype looks like without doing the actual expensive and maybe invasive genetic test. And I say invasive because I'm thinking of invasive on your wallet and invasive on your publicly available history. So some of the genetic companies that goes into your chart, and that can affect your like life insurance and stuff like that. And then when we look over at addiction, which is one of my specialties, we do see particularly opioid receptors, the dopamine receptors, and the MTHFR gene highly linked. Inflammation across the board, diet, lifestyle and diet. We've heard, oh my goodness, from the first two speakers today, especially Dr. Littig, highly linked to fructose, to processed foods, and then also certain food colorings, highly linked to attention issues. Allergies and hypersensitivities are also very linked. And so I think there were some questions.
I want to just piggyback on how critical I think the processed food piece is as the central biggest problem for diet. From my perspective, I will often simply start with having people cut the amount of processed food, and I see metabolic improvements, I see mental health improvements, I see gut improvements. So I couldn't agree more with Dr. Lustig's approach and his perception. I see it clinically all the time. So I just wanted to throw that out there and keep going.
100%. I mean, and definitely it is so highly linked to so many. Even you saw the liver improvement with just 9 days of removing fructose. God, that's amazing. Mold across the board in these disorders. So we'll talk deeply about this, but do you want to comment right now?
Yeah, So just the piece here is that, as I started off practicing regular old functional medicine, there were things I needed to learn to get my people better, right? And one was the gut. I fixed the gut, and a lot of people went on their way and got better. But then there were still just this chunk of people who wouldn't heal, that had ongoing, psychiatric disorders, seizure disorders, mood disorders, chronic fatigue, and the vast majority of those people have mold. Particularly here, I mean, we're in New Orleans, right? We live in a swamp, but this is a problem worldwide. In my past gig, I was a medical director, and I would interact with patients all over the world, and people from New Zealand to Italy, England, Scotland, Canada, you name it, they were coming to see me, and it turns out they were being made sick from mold. So we see this a lot, and I just want to emphasize, if someone is not getting better and there's mold exposure, that has to be treated and dealt with. So we'll talk more about that. And I know Dr. Carnahan is speaking tomorrow. So Jill will probably say some awesome things about that. So I'll just pick up maybe their heavy metals. Again, this is something that we'll mention later. In my practice in particular, typically people have already seen a number of doctors, integrative, functional, conventional, and they're still sick by the time they make it to my office. And so I'm already sometimes looking for, okay, what's been missed? And if mold is number one, heavy metals is also, say, processed food might be number one, right? Mold may be number two, heavy metals is number three. And we can maybe get into some cases later, but I'm seeing really problematic levels of mercury, lead, thallium. Just last week, a case of alopecia totalis caused by thallium toxicity. And so heavy metals are absolutely being missed. And I don't want to steal Dr. Pizzorno's thunder, but Dr. Pizzorno is the man to listen to tomorrow here as well. And then Arwen, I'll throw it to you for hormones.
Yeah. So, I mean, hormones, this can be at any age, but certainly I see so many women of a certain age that are maybe perimenopausal, and they have new onset anxiety, depression, insomnia, attention issues, fatigue, all of these. And if we miss
And you
the
slap a
hormone,
patch on, you slap an estrogen patch on them, and 4 days later they're like, "Oh my God, I'm back." You're
right.
like,
Whereas
"Ah."
our traditional psychiatric treatment for those takes quite some time, and we're not treating the root cause. We're kind of just putting a Band-Aid on it. So I like to do both. I like to do hormone workup, and I'll defer to Felicia later today to do an excellent talk on hormones. But it is associated with all of these dimensions or all of these symptomologies. You guys get the slides. This is our references. You can take a deeper dive into these.
That's so we didn't make the last slide up. This is pulled from evidence.
Yeah.
All right. I'm gonna take lead on this one, and this is going to be a high level overview. We're going to talk about a lot of these things more, but I wanted to just mention each of these pieces quickly. So when someone is coming in with mental health complaints, really, many of those are driven by problems in the gut, whether it's SIBO, whether it's dysbiosis, whether there are infections. We'll talk about and touch on these later. The gut is really, really important not to miss. We get a lot of the information from history. Sometimes we'll do SIBO breath tests or stool testing, but not missing gut problems is really critical. The HPA axis is very important here. I'll talk about how I use a lot of adaptogens, adrenal adaptogens in my clinical practice without testing, right? Someone comes in and by the time they see me, they are fatigued, right? They're burnt out, and adaptogens help the vast majority. We touched on nutritional deficiencies already. We touched on genetics, inflammation, ordering a CRP. Sometimes it's as easy as that. Many people now, you can look at a patient and tell if they're inflamed, but it's important to think about, why is this person inflamed and how can I get that better? The test I use the most for mold is both a clinical interview. So for me to consider if someone is made sick by mold, I want to know, have they had a clear exposure, right, to mold? Not just maybe sort of, I think, but was there a clear exposure to mold? Did symptoms worsen after that exposure? I think that's another very important component to have, right? If it's their home, can we test their home with like an ERMI with immunolytics plates, or maybe an inspector to determine there is mold there or not, right? And then finally, I like to use urinary mycotoxin tests. If I have elevated levels with all of those history pieces, then mold is the player until proven otherwise in my practice. So
and like what we know, we were both seeing patients after Hurricane Katrina, and we had this whole terrible debacle where there was this mold infested sheetrock that was put in
the Chinese drywall. Yeah,
that's right. Chinese, not sheetrock drywall. It was put all over, and so it actually is proved to have black mold. And so many people got sick, not just from the mold that was endemic from having been in certain areas under 10 feet of water for 14 days. And mold growing left and right, but from actually bringing it in an infested form into a new home. And so we don't, we've had apartment buildings, we've had low income housing, we've had very high income mansions that used this product. And so we really have to, our radar is high up for mold.
I got a call 6 months ago from one of the mold inspectors in town. And a family moved into a very, very expensive multi-million-dollar home that was just built, and they installed a window improperly, and it's full of mold, right? The water leaks through the wall. And so it doesn't matter how expensive the home is. It doesn't matter how newly it was built. I can still get moldy. Right. Hurricane Ida, I mean, now I'm seeing the latest people becoming sick from Hurricane Ida who are now coming in with mold-related problems. So it's definitely out there, and people need to, if you're not familiar, Jill Christa, Jill Carnahan, Neil Nathan are some of the best educators here in the field. I know Dr. Ackerley has a lot of experience with mold. And so there's tons of good information out there, and addressing this really needs to happen. Heavy metals, I think we mentioned that enough. What I will say is that how I start screening for heavy metals is a blood draw plus a urinary test. I do a random, unprovoked test of both of those on the same day. And in my mind, that's the single best evidence-based way to capture heavy metals without having to expose someone to some of the chelating agents, which may make them worse. By the time someone comes to see Arwen and I, right, a lot of them are very sensitive and vulnerable. And a lot of the heavy chelation treatments that you'll read about and are taught in some of the functional medicine courses are just really inappropriate for these patients. It will really hurt them. And so I don't think they're needed. And so I hope that what we can get from this is just a single random first morning urine. I use doctor's data as the urinary test, plus a blood draw from Quest or CPL or LabCorp. Really, really has a high degree of sensitivity and specificity in my practice. Hormones, I'll go real quick. I no longer use the urinary or saliva testing. I don't think those are as accurate as the blood work. And so particularly for menopausal women, a simple blood panel, estrogen, progesterone, testosterone, I think is the vast majority of what you need. And then some of the metabolic markers that I assume Dr. Lustig touched on. In my practice, the worse the fructose of the metabolic disease is coming in, right, the more the fasting blood sugar will be, right? The higher the A1C and the higher the fasting insulin. And then for lipids, I'm a fan of a standard lipid panel. So getting an LDL is usually calculated. And I like to back that up with an ApoB, which can be gotten from all the standard labs, plus an LP(a). I think the lipid panel plus the ApoB plus the LP(a) gets you most of the way there. So let's keep rolling, Arwen. We got slides.
We got a lot to talk about. I want to comment on blood work and we talk about it individually when we get to these different headings. But regarding just a larger blood panel, we can kind of provide like what my overview would be towards the end if we want to. But regarding, it used to be that hormones were price prohibitive to order, and now most insurance companies are covering it regardless of who's ordering it. Yeah. Even a psychiatrist, most of these are getting covered. An NMR or an ApoB, LP(a), those are also being covered. And so that's why it's easier to get them from our perspective at this point. You don't have to go to a specialist and pay out of pocket for every single thing.
All right, so what we have here, the 8 bullet points that you see there are things that we're going to spend a few minutes on. So I won't read those because I'm just about to tell you about them. But at the bottom, you'll see in italics, there's some others that just couldn't make the cut. We didn't have enough time, right? But things that we see help our patients. And so here's kind of the honorable mentions. We love them. We're sorry that they don't get a slide of their own, but they're still great, right? So omega fatty acids for mood have a place. Arwen uses a lot of SAMe in practice, and I've seen that help my patients when they come in and they've been boosted up by Arwen on some SAMe. That can make a big difference in brain fog and fatigue. Fasting is one of my absolute favorites. I am sure that Dr. Lustig talked about this, but this is a huge way to change neurochemistry. And there are reports of 14-day fasts completely reversing cases of autoimmune disease, completely wiping out major depressive disorder. And using it doesn't always have to be 14 days, but sometimes a 2-day water fast or a course of elemental dieting can really mimic this and have a really great response. We've got acupuncture, we've got exercise. This is just missed so often. Even our most fatigued patients, we can use progressive exercise therapy. It's found in the literature for PET, right? So we know that just starting with walking as little as a minute a day and then moving upwards very, very slowly can start to help wake up some of the cellular mechanics that have been turned off and start moving the body's lymphatics and start waking up the nervous system, moving the gut along, waking the hormones up, getting the body reset to the circadian rhythm. It is the benefits of just starting to exercise are so fundamental and so important. And then light therapy for our patients in the particularly more northern latitudes. Sometimes the light boxes and light therapy can be life-saving. Anything there, Arwen, that you want to chime in on? Or
yeah, so omegas are kind of indicated for every set, and you heard from Dr. Lustig and Dr. Hedaya about omegas. I believe, I can't remember who talked about the pathway, but anyway, very important for all different aspects of mental health and brain chemistry, and kind of they're, related to the building block. We're not getting into the details of that today, but I highly encourage you to know that that is one of the dimensions that you really want to.
And know that high dose can cause AFib. So that's just something else to look out for. So if you have someone with anxiety and palpitations and you're high dosing them with omegas, is it the omegas? Is it their anxiety? So just another word of warning.
But this is why we're showing you this slide and why we're going through these 8 modalities. There are these 8 treatments, is because this is the evidence-based treatments that are non-pharma that we tend to lean most heavily upon. And between Joe and I, we've found that some combination of these after appropriate workups and clinical evaluation really does lend to a wildly successful improvement in patient symptomology. So I'm going to jump in and just start talking about some micronutrient replacement. So I often will do these replacements after a blood value is determined, particularly vitamin D. Vitamin D is on my initial blood panel. We've heard from many people that vitamin D is highly linked to major depressive disorder, also is linked to fatigue and immune boosting or immune wellness. So during, prevention and treatment of COVID, everyone started taking vitamin D. But remember, there is a toxic threshold. There is a therapeutic window that is pretty big, all the way up to 100 milligrams in your blood draw, but we don't want it to go too much higher. And so we want to make sure that we're dosing appropriately. Many people mention that the good dose of vitamin D, or sorry, not the good dose, the good blood value for vitamin D is between 50 and 80. Some people say 60 to 90. What do you say, Joe? Where do you try and aim for patients?
Well, this is one of the things that's going to get me kicked out of the integrative medicine club. I don't like optimizing vitamin D. I don't think it is that beneficial. I think if someone's deficient, then it's indicated. When people come in and they're taking vitamin D, I generally want them to have a serum level of 40 because we know the vitamin D assays are not very accurate. So it may be as much as plus or minus 10 on the vitamin D, right? So if the normal level is 30, I want to get them to 40.
Right. And I want to get them to 80.
I know that they're at least at 30.
Yeah, and I want to get them to 80 because it does correlate with depression lifting and fatigue lifting. And so,
so it's a judgment call here, right? So
that's where we have these fun conversations. And so
might be someone comes in and, I say, okay, well, I only have so many pills I can make this person swallow, right? Is vitamin D going to be the one, or do I really need to get them on binders because they're being devastated by mold? First. Or are they doing pretty well and everything looks pretty good and we can maybe just try some optimized nutrition because they're not that sick, right? So this is where the fun art of medicine, right, comes in.
And then what's causing the vitamin D deficiency? I have somebody who takes 10,000 a day and his level's still not high enough. And when we dove into his actual root cause genetics, he has 2 genes that are double homozygous that make it so he cannot absorb vitamin D in the gut. So we have him on 10,000 every single day, which that would be topper for any of us, for most of us, and we would get toxic on it. And so you really have to think about the individual and maybe why they're not absorbing, and maybe they have their toxins in their system that you need to chelate out. And so you're right, not addressing that first, but that's a low-hanging fruit. And it's been really thought well about over the pandemic because of its relationship to immune boosting. B12, very commonly used by patients. A lot of my patients have their own B12 injections, and then I get their labs and their B12 is through the roof. And of course, we know that you can have too high of vitamin B levels. So we would very much like it to be in a therapeutic range, and B12 injections sometimes overshoot that. And I actually have someone who had significant neuropathy due to weekly B12 injections, thinking that he was doing himself a favor for energy. Activated folate, there's loads of data related, the RCT, routine randomized clinical trial, 0.8 mg of folic acid a day decreased depression symptoms. Loads of other data that talks about activated folates. We'll get into that in the next slide. Omegas, I said we weren't going to talk about that, but we are going to talk about it a little bit. But you saw the slides from previous speakers that meta-analysis that where the pathway is. But EPA is very well shown to stimulate mood. And then we have lots of data on it related to attention and fatigue. Cofactors, of course, we need these cofactors. So here's our patient that we talked about.
Back to the beginning. So Arwen had worked this patient up and the patient had stabilized to some degree, right? I want to say that there was 2 or 3 medication trials and symptoms were better, but still pretty bothersome to the patient. And so what we did is we collaborated, we talked on the phone, and then I got the patient into my office and did a little bit more workup. And for this patient in particular, it was mold, I think, that was missed. And so it's just a good vignette to, we can get all the right tools into place, but if some big toxic insult is dragging someone down, there's going to be a ceiling on how well they can get, right? So when we found that, right, we were able to adjust, get the patient out of mold. Arwen did a second round of psychiatric care and the patient took off, right? So that's where we see some of the SAMI. She was in a place where SAMI was ready for her. The limbic retraining, I believe this patient did DNRS and did excellently. That really helped. And then responded to mold treatment, right? So binders to remove the toxins. There was remediation of the home. And then I moved on to use, in her case, herbal antimicrobials to clean out the mold burden in the body. So that was this patient. And it was a case where Arwen started, stabilized. I found the mold. And then once we found the mold, we were both able to have our treatments work so much better than if I had just done the mold or if Arwen had just done basic psychiatric care. So it was a real fun case. And we see things like this all the time.
Exactly. And listen, I want to mention, and we're going to wrap up for questions in a second, but I want to mention that, yes, her zinc was low. But why was her zinc low? Probably because the toxic insult was removing the zinc, because it pulls out when you have such toxic insults. She actually moved to another house. Her whole family moved. She found out that her kids, I saw her last week, she found out that her kids had toxicity as well that were manifesting in some really difficult behaviors and learning issues. And so they moved, I want to say like a year or two ago, and that continues to do the interventions that we're needing. But she is, in the 80% better. Whereas when she was seeing a traditional psychiatrist and a traditional primary care, she wasn't able to get to this level. So it's been very impressive. So what we know, and then, as a mental health provider, I know very well that there are mental health issues that are just neck up in a bubble, but very, very rarely, they often and almost always manifest from some sort of biological root cause. So we want to collaborate, because collaboration outcomes truly are more than the sum of their parts. And we want to also know several workups and effective and precision treatments, because I get great reviews from my patients, but I want everybody in the field to get great reviews, and I want the field to get great outcomes. High number needed to harm, low number needed to treat. That would be ideal.
So if you're a family medicine doctor, you need to find an Arwen and you need to bother them and text them until they help you with your patients. And if you are a psychiatrist or a nutritionist or dietitian, you got to find people who supplement your skills, right? It's just how it is. And it makes it so much more fun. Collaborating with you, Arwen, has just been a blast. It makes medicine more fun. Our patients get better quicker. And so everybody find a buddy.
Yes, we make medicine more fun. That's awesome.